I'm Dr. Lauren Chasen, and I'm going to talk to you today about pediatric respiratory illness. Most of you have seen a little guy that looks like this come into the office. So I'm going to talk to you today about how to determine if the child is toxic looking, if there's an increased work of breathing, the child is dehydrated, and from there we can distinguish whether it's an upper or a lower respiratory process to help make the diagnosis a lot more clear. Most of the time babies are very cute, but it's a different story when we are talking to the parents. But today I'm going to give you all the information you need to know to nail the diagnosis. So first question to ask is, how sick is the baby? That's what the parents want to know as well. So in order to figure that out, we need to determine if there are any signs of toxicity. Is the kid really sick? First things first, a child 3 months or less always goes to the emergency room for further workup to rule out any occult infection or bacteremia. It may seem like overkill, the parents may not be happy, but it's very important to make sure that there's no other hidden causes of infection that need to be ruled out. The next thing is that in a child 1 year old or less, the most accurate way to measure the temperature is rectally. And the third drawer of the exam table, we have this red part here that can fit right into the thermometer, and we use a little of the lubricating jelly to take the rectal temperature. We advise parents to do this in a child 1 year or less at home if they're concerned about measuring the temperature. And in the office, we would do this only if it will actually change our management, and our plan is contingent on whether the child has a fever, and particularly in a child 1 year of age or less, and also up to age 5 if we're really not sure whether the child needs to go to the emergency room. The next thing to ask is about the breathing. So it's important in a child to count the respiratory rate for a full minute because breathing can be irregular, and look for signs of respiratory distress or struggling with retractions, nasal flaring, accessory muscle use, stridor, or a pulse ox less than 95% on room air. Then we need to ask ourselves if the child is peeing okay, and we need to ask a few things about this for the parents because sometimes it's a little bit hard to tell. A typical infant will have 6 wet diapers a day, but 4 wet diapers per day is reassuring. Signs we need to look for, including trying to figure out if the baby's acting funny, is are they lethargic? Do they have sticky mucous membranes? Are they not connecting well with the parent? Do they just not seem right? We need to ask those questions of the parents, and we can also ask that of ourselves when we evaluate the patient in the office. Behavioral differences will give us a very good indication of how severe the illness is, and we'll be able to breathe easy and know that the child is not toxic, does not belong in the emergency room, and we can go on with the exam to get the rest of the information. Once we've decided that they're not dehydrated, not toxic looking, not having trouble breathing, now we can move on. Even if this is the family and the mom that you see in the office, I guarantee you that this is more likely the case of what's going on inside the person. So you'll need to ask some very specific questions to get the details that you need in order to make your decisions and to go along your diagnosis. The day of illness is a particularly important part of the story, and frequently the parents won't recall, but we'll need to ask some questions to find out when the fever started, when the initial symptoms started, and what are the surrounding symptoms that happened during the course of the illness, and document this in the chart. So the day of illness is very important because if the child has been ill for 7 days with a high fever that entire time, it's a much different picture. One of the things we need to worry about is that the child has had no fever but had respiratory symptoms or a cough for a couple of days and then develops a fever. That is much more suspicious for an superimposed bacterial infection that might need to be treated with antibiotics, as opposed to a child that has no fever. And different illnesses can appear with a rash. If there is a rash before the fever, that is more indicative of a viral upper respiratory infection, as opposed to a rash after the fever, which is more likely to be more serious or could be indicative of roseola, for example. So associated symptoms are very important. The sequence of the symptoms, the method of the temperature measurement is important because we need to ask to make sure that an infant is having the temperature actually measured, and if it's an odic temperature of 102, then we know that it's probably going to be higher than that because the most accurate way of measuring the temperature in an infant is rectally. Then we need to keep in mind the risk factors involved in each case. Birth history is important up until about age 2. If the child is born premature, they are more predisposed to having chronic infections and lung infections. If they recently have been on antibiotics, that predisposes them to more serious infections if this child is ill. If they are not immunized, then they have a higher risk of Haemophilus influenza-related infections such as epiglottitis or pneumonia or meningitis and strep pneumo infections. Kids that are in school or daycare can have higher rates of communicable diseases, so we need to ask specific questions of the parents about this. So once we have now determined that the child is not toxic and we have gained a little bit more information about the course of the disease, we can then distinguish whether it is an upper or a lower respiratory process. But first, a word about influenza. This is usually self-limited, especially in kids that are vaccinated, and you can refer to the excellent learning bite on influenza, but typically we have a patient with influenza, a child would have upper and lower respiratory symptoms. It can be more abrupt onset of fever and headache. If you suspect these symptoms with an abrupt onset of upper and lower respiratory symptoms, please do test for flu, because this is definitely would give us a lot of more information about how to treat. So once we have eliminated that as a possibility, we can think about upper respiratory illnesses. And in upper respiratory illnesses, we find most commonly, we'll talk about croup and a viral illness, but less common would be just a brief word about epiglottitis. It's a little bit more common in children who are not vaccinated because that is caused by Haemophilus influenza. Foreign body aspiration is usually evident based on the history, and bacterial tracheitis, kids are very, very sick. So all three of these are kind of acute situations which would likely warrant sending the child to the emergency room, but just good to keep in the back of your mind. You know, most of you will be easily able to diagnose their viral upper respiratory illness, so we won't spend too much time on that. This is otherwise known as the common cold, and usually supportive treatment is enough. Now, croup is an inflammation of the upper airway, and for those of you who do not know what it sounds like, we'll play it right now. So that is what croup sounds like, and it sometimes helps to reproduce the sound for the parents, because once you do that, they will know exactly what that is. So if this kid came into the office and was coughing and possibly sounded a little bit like a barky cough, do we suspect that this child has croup? Probably not, because the most common age of croup is between 3 months to 3 years. It's most commonly found during that age group. It's a younger illness and would not be typically found in school-age children. The treatment for croup is Orapred, 1 to 2 milligrams per kilogram for 3 days. And the reason for this is this is not absolutely necessary, but at times it can help the child. It can be dosed in a twice-a-day dosing or a once-a-day dosing, and it sometimes helps to give it once a day at night, because that's typically when the symptoms are a little bit worse. There's some evidence behind steroids to treat mild croup. Again, if the child has any severe stridor or appears to be in respiratory distress with a severe croup, they need to go to the emergency room. But what about dexamethasone? Dexamethasone, the one-time treatment of 0.15 milligrams per kilogram times 1 immediately is actually a great treatment for croup, but it is difficult to find in pharmacies. It's difficult to dose, and due to the it's not easy for patients to get this, and it's not easy for parents to measure out. So at this time, we'd like to recommend that you give the Orapred. Moving on to lower respiratory illnesses. We're going to start with bronchiolitis, which I'm sure most of you have seen. We call these kids the happy wheezers because they typically do not appear acutely ill. They have a fever but are usually not toxic. It's important to tell parents, however, that the cough can last for about 2 weeks because it's part of the disease process, and it might seem a bit longer than other viral upper respiratory infections. Its most common cause is RSV. It's more common in the winter. Treatment is supportive. You can use a bulb suction and a nasal saline, and if the child looks acutely ill, then they do need to go to the emergency room. This also affects kids between the ages of 3 months and 3 years. And again, really remind the parents that it can last for about 14 days so that they don't worry and become upset if it doesn't go away in the next couple of days. An important thing to remember is sometimes if a child comes in wheezing and the parents are very concerned about whether they have asthma, if there's no prior diagnosis of asthma, then we need to rule out other causes of wheeze. First time episode of wheezing in a child less than the age 2 or younger is actually bronchiolitis, but asthma also has a different clinical picture. It's not infectious, it's more seasonal. They often have nighttime cough, and it's important to ask a lot of questions about the cough and the other associated features with the illness. It's okay to treat asthma, but it's important that we make sure that we first ask questions about the history, make sure that the parents understand what's going on, and that we also make sure that the patient comes back. If we're going to treat asthma, the patient must come back for follow-up to monitor their course. Next, another lower respiratory process we're going to talk about is pneumonia, which is treated just a little bit differently in children than it is in adults. So the first thing always to remember is same thing as before, is whether the child is feeling acutely ill, if there's any respiratory distress or any breathing that warrants a visit to the emergency room. If everything is definitely okay, then we can take a step back and look at the picture. Is it viral or is it bacterial? Viral pneumonia is actually common in children, typically presents like the common cold or a viral upper respiratory infection. The course is mild, and sometimes they don't even come into the office. Typically they're afebrile or they have a mild fever and they get better. So if it's a bacterial infection, pneumonia in kids can present. We typically look at this based on age, and this is a little bit different than the child with a fever 3 months or less. If you suspect that the child has pneumonia and they are up to 6 months old, we still need to send them to the emergency room because this can have bacteremia and sepsis that's associated with the pneumonia that's hard to pick up in the office and warrants further treatment and testing. So as opposed to a child with a fever, 3 months and younger goes to the emergency room. If you think they have pneumonia and they're 6 months or younger, they need to go to the ER. When you're figuring out if they have pneumonia, question to ask frequently comes up: do we get a chest x-ray? Do you need a chest x-ray? Chest x-ray is not necessary in children to diagnose pneumonia. Number one, it's not as accurate as is in adults because it's not as easy to differentiate in a small body. It doesn't affect the outcome, and it it is not a necessary thing to diagnose it. So we don't get it for kids typically. Now, the caveat is that if the child comes back and there's further testing needed and we're not sure, that's a consideration, but that's something to determine on a case-by-case basis and not to determine whether you need to treat something for pneumonia. The treatment for pneumonia is divided by age in children. So in a child 6 months to 5 years old, we assume first of all that it is most likely to be strep pneumonia, and we treat this with high dose amoxicillin. So we do this in an age group because this is the most likely pathogen for this particular age group. These kids apparently appear a little bit sicker. They have higher fevers. They usually have a quicker onset. They can have a little bit of cough, and sometimes the cough doesn't show up for a few days because alveoli have just very few cough receptors. But if the child has upper respiratory symptoms and for 3 days with no fever, and again presents then has a fever, that's very suspicious for bacterial pneumonia, and recommend treating with a high dose amoxicillin. The dosing for amoxicillin for this age group is 90 to 100 milligrams per kilogram per day in 2 or 3 doses. So if they have an allergy to penicillin, if it's not a type 1 reaction, that is they do not have anaphylaxis, then you can give Omnicef. And if they do have a type 1 reaction history, then you can give clindamycin or azithromycin. For a child that is 5 years or older, we're going to first assume that they probably have an atypical pneumonia or mycoplasma and treat first line with azithromycin. These kids typically present with a picture of a more gradual onset, low-grade fever. They can have sometimes a sore throat, sometimes a stomachache. They're not acutely ill. And we treat with the typical dose of 10 milligrams per kilogram on day 1, followed by 5 milligrams per kilogram daily for 4 more days. Now, there is children 5 years and older can also get strep pneumonia or bacterial pneumonia, and what we would do is if the child is acutely ill, more different than the gradual onset of an atypical pneumonia, or if they are not responding to the treatment for the if they did not respond to a macrolide treatment, then we would suggest giving amoxicillin high dose for over 5 years of age. To review, child less than 3 months with fever goes to the emergency room. Child with a respiratory illness must first be assessed for toxicity. Red flags for increased work of breathing are respiratory rate over 50, nasal flaring, retractions, accessory muscle use, and pulse ox less than 95%. Ages 3 months to 36 months old with a barking cough and a runny nose, think croup. 3 months to 36 months with a cough that are happy wheezers, think bronchiolitis. Abrupt onset fever, cough, tachypnea with abdominal pain, or URI symptoms for 3 days and then a fever, think about pneumonia. 6 months or less with suspected pneumonia, we send to the emergency room. Treat pneumonia in a child 6 months to 5 years with a high dose amoxicillin. And pneumonia in a child 5 years or older, first line, treat with azithromycin. Next, for the parental guidance, because none of this can happen unless we advise the parents. So they do not do this. And the most important questions that we need to answer for the parents are, what does the child have? How long will they have it? How'd they get it? Is it contagious? And how can I make it better? And how can I prevent it next time? What should I look for if it's getting worse? And what do I do if it's getting worse? All of these can fit really nicely into a magic minute. And then your parent is trained, the child is treated, and you have successfully treated your patient.